health. Okay, so thanks everyone for joining us today. I realize this is the one free day for students and theoretically for faculty, but we also know that that isn't true. So I want to tell you a little bit of background about Whole Communities Whole Health. And we're one of the 3 grand challenges, Bridging Barriers programs at UT Austin. Next slide, please. We launched officially in 2018, and one of the motivations for our work is that we looked around. Well, if you look at the state of Texas, for instance, you see that despite what we see of all the rapid advancements, if you will, in Austin, there's the state of Texas, and particularly families with children in the state of Texas face a lot of stressors. So just as an example, 11% of all children in the US are born in Texas. We rank something like 43rd in overall child well-being. We rank very poorly in socioeconomic disparities in child health. A quarter of the children in Texas live in poverty. And of course, we have a very rich Hispanic population as well. But what we started to see, next slide, is that families in the state of Texas are facing a lot of stressors. And specifically, what we're trying to understand is, can we come up with a new way of engaging with families and communities to improve everyone's lives? So specifically, Whole Communities Whole Health, our mission is to better understand and address what matters most to communities facing health disparities, so families can lead healthier, happier lives. Our research team includes folks from social work, communications, engineering, health, psychology, and in fact, 27 UT departments are members of the Whole Com research team. Next slide. So what we wanted to do is specifically look at families with children, and specifically young children. And we wanted to understand not only just the physical health of the families and the family members, but also the community health. We wanted to look at social and emotional health, and also environmental factors that could be affecting the health of our community members. But so this is kind of a multidisciplinary or interdisciplinary effort across many different departments. And specifically, we wanted to kind of reinvent or reimagine how research could be done with community partners. So instead of kind of the typical process where a research group decides what the question is, goes into the community, does the research, and then writes some papers and moves on to the next research question, we really wanted to partner with the community members to have them guide us as to what questions they would like answered. And then when we come up with the research process, or as we're doing this research with our community members, we don't want to, again, just take the information and write some academic papers. While that's very good for advancing the science, we also want to give feedback to those families so they have that information so that they can advocate and improve their own well-being. Next slide. So we began this process first at UT. So we've run on the order of 3 large pilot studies, about 3,500 participants to date, where we've been looking at how we might leverage technology to collect information about, for instance, environmental exposures in this example, more quickly, so that not only can the researchers use that to advance, develop, healthier homes, for instance, but also so that we can give the information back to our participants so they can understand, for instance, if the CO2 level in your home is too high, that suggests that you have poor ventilation. How about you open a window if you can, or run the vent when you have particle concentrations that are, or dust concentrations that are building up in the home. So this is just an example of the types of rich data that we can collect using the Bevo beacon as an example here of some of the technologies that we've been utilizing in our UT studies. Next slide. So we didn't want to just develop, again, technologies and other methods for collecting data. We wanted to be able to feed that back to the communities. And so this is an example of the dashboards we're developing. For instance, if you're looking at sleep quality, you have a wearable Fitbit and you want to know how well you slept last week compared to the week before. The idea is not just to collect that data, but again, give it back to the community members so they can look at it on their phone as an example and have a customizable dashboard, we call it, so they can get the information back and make their own decisions about, for instance, am I getting enough exercise, or is there maybe the particle concentrations or dust concentrations in my home are too high, maybe I should open the window or ventilate every once in a while. As some examples of actions that family members can take once they're given the information to make their own decisions. Next slide. And as an example of some of the community activities that have been going on, we have a community strategy team that has been guiding our work throughout the process. More recently, we did a series of community talkabouts with the community in Eastern Travis County that we're working with. And we use that to guide what actually are we going to measure in homes, what is of concern to the community, and how can we help them answer those concerns and address those. Also, through this process, we've already identified several concerns that are obvious within the community. So, of course, this is in the age of the COVID-19 pandemic, and getting access to vaccinations was a significant concern for our community members. And so we teamed up with VAMOS to help with the pop-up vaccination clinics that are still going on weekly now in these communities. We also heard quite a few concerns about air quality in the community. And so Dr. Mitzal and his team, if you look in the lower right there, outfitted a car, put a state-of-the-art instrument that barely fits in within that small vehicle, and drove around to do real-time measurements of air quality throughout the Eastern Travis County to try to identify what are some of the air pollution sources of concern and what can we do about them. And then, if you're looking at, for instance, physical activity is hugely important for families. And so some families don't have access to, some sporting equipment and other things that might encourage physical activity. So working with our partners in the school districts, we've been distributing activity bags to the children in these communities. I think click next and maybe something will pop up. One more next. Oops. Oh, or disappear. That's a new way to go. So I do want to mention we are now at the point where we've run a series of with thousands actually of UT participants of studies to work out all of our different processes. So in one study, for instance, we can look at the social determinants of health, we can look at mental health, we can look at physical health, we can measure indoor air quality as an example. So we've got this really diverse team of researchers that's working with us to really give a much more comprehensive measure, if you will, of the different aspects that can influence health outcomes. And so we are now taking what we've learned over the last 2 years and rolling it out to our community. And in fact, we ultimately are hoping to work with about 300 families within this community. But we're beginning with our ambassador families to begin with, and that actually will be starting likely within the next month. So with that, go to the next slide.
I think that's the end.
Oh, well, with that, I would like to invite all of you. Sorry, there's one slide missing. With that, I'd like to invite all of you who are interested to reach out to Whole Communities Whole Health. There is quite a bit of research going on. As I mentioned, there's 27 different departments represented. And I'm sure that if you have an interest in the health of families and children, that I'm sure there is some role that you can play in this project. So please reach out to us if you're interested. And with that, I'd like to transition over to our speakers today, which will be talking about how we can use GIS technologies to both understand and understand health disparities and promote healthy communities. And so with that, I think our first up is Zhang Min. Zhang, who's a faculty member in the Department of Civil, Architectural, and Environmental Engineering. And he's very well known for his work within transportation engineering, but he's also done some very interesting work recently in response to the COVID-19 pandemic. And so with that, we'll let him take it away.
Well, good afternoon, and thank you, Carrie, and for the introduction. And so what I'm going to do is to use a few slides and just to highlight the work we have done using GIS and in characterizing some of the things related to COVID-19. So as you can see, well, I'm actually in the transportation group and of the CAE department here at the UT. And so some of you may question, say, well, and as a transportation professor, what are you doing with COVID-19 pandemic? And so I'm going to address this and through my discussion here, and by just very quickly, for one thing, as you know, the pandemic has been closely related to transportation, whether it's air transportation or surface transportation, because the spreading of the virus and it's closely related to transportation. And then secondly, the reason I'm doing this work, that's because in my research area, and it's also in resilience. And so if you think about community resilience, and it's essentially the risk, exposure, and vulnerability when it comes to the pandemic like COVID-19. So the work we have done was like different than some of the other dashboard and a lot of the data being tracked and reported, but our work here is more kind of focused on the resilience aspect. And so that's basically the three aspects I'm talking about: risk, exposure, and vulnerability. So this is also just as a very quick background. And when you think about inner resilience, and especially for communities when it comes to pandemic, and there are three important things, and that essentially lead to the risk. So one is a hazard, and another is a exposure, and the third one is vulnerability. So the three together essentially and give us a risk. And then of course, and the resilience is a function of the risk and the capacity we have, and also some of the countermeasures we typically take. So then if you look, for example, vulnerability, and there are a number of factors that affect the vulnerability of our communities in terms of a pandemic. And for example, if you look at that figure on the left, it's basically the distribution of the population and of 65 and plus. And also another interesting figure, if you look at, for example, the impact of population distribution on the right-hand side, you can see as well, and those dark area. And you can see, look at the map, is very small and in terms of the area, but it covers half of the US population. So that's how our population is distributed. And so just give you basically the examples about when we look into vulnerability, those are the things we do take into consideration. And also in terms of capacity, and we definitely look into, for example, hospitals and ICU beds and the different distribution. And with, you can see the left-hand side, right-hand side is basically, one is basically the hospital and another basically the ICU capacity. So we are all aware of that. So, well, this capacity has a direct impact on the resilience and when we think about a community. And then mobility. And I said, well, this is a major reason for me and get into this also. So well, just look at the transportation. Anybody saying something? All right. So, and so the mobility, as you can see, is both national and international. There is an impact. And as you probably still remember what we have done, and internationally, so we shut down our airports, and then locally, and we put different kind of restrictions on people's travel, and say, well, you cannot go out and just basically and stay at home and all of those things. So, well, that's a direct impact and on the pandemic. And then, of course, the number of cases, and that has a direct impact on the risk and the resilience of our community. And so this is basically just a very quick view, and basically based on the data, and you can see this is a little bit old because, and we have new data, but we haven't really integrated into a display like this, but our dashboard and has been kept up to date. So the cases, and the left-hand side, you can see the cumulative cases and by the different regions. And right-hand side, you can see it's basically the daily confirmed cases. But just like for your information, you know this very well. The number of cases is typically lower than the actual number of cases. So the number of confirmed cases is typically lower than the real number of cases because those confirmed cases are based on the number of tests we have conducted, right? So we didn't conduct the test and for everybody. That's the reason. Well, this is just basically illustration. And then another very important factor, and we have to take into consideration, well, responses from government agencies and also, in a way, from the citizens in our particular country. So we're using and stringency index, and which is basically developed by the University of Oxford as one of the attributes and in our dashboards. And so they keep updating this stringency index and over time. So this is just an example you can see and across the world and how each country is responding to the pandemic. So using this different kinds of information, and then our dashboards include 6 indices. Well, essentially 5, and because we're sharing the exposure in the middle, and that's both for fatality and vulnerability infection. So you can see we have the infection and vulnerability and the infection risk. And then the exposure is basically an important factor and in calculating the infection vulnerability and infection risk, and also fatality vulnerability and fatality risk. So then in terms of the data, and we're using like data sources from a number of places. And here it's just basically a list. I'm not going to read through this, but you can see some of the data sources are obvious, and everybody has been quoting those sources, like, for example, US Census Bureau and then Johns Hopkins University, but there are other data we also use from Federal Aviation Administration and also from some of the companies. And that's for US. For international or worldwide, and primarily our data sources basically, in addition to Johns Hopkins and the International Civil Aviation Organization, and then we were using that from the World Bank and also the World Health Organization. So then, of course, with the data, the next steps, well, we're talking about this is a forum and closely related to GIS. And so we're using like E3, the ArcGIS software, and also Python as a programming tool. So I had 6 PhD students that will work on those, and basically some of them work on data modeling, some of them work on coding, some of them work on and put the information in cloud, and then so that the user can access it. And so this is just a quick view, and you can see, and we were using ArcGIS and then the online publication tool, and then went to get to the cloud and with some of the information. So the end user is actually accessing the information, the dashboard from the cloud. Just quick example, for example, if you look at the dashboard and in the middle is a map, and then at the bottom, and we have a very quick statistic showing the different levels of risk and for either the infection or the fatality. And then on the left-hand side, you can see, and that's basically an example and showing the infection risk. You can see it's based on the numbers, and right-hand side is a fatality risk. And also, if you click on a particular country or particular county, and it's not that clear because I enlarged the image, and you see and like an infographic and showing some of the details. So that's essentially the work. And once we had this developed, and we did receive some good media kind of exposure, and from internal UT here, but also and news agencies here in Austin. And so, and I was on Fox News. I also did a live interview. And so this is the dashboard URL. And so I was going to do a live demonstration, but because of time limitation, but also at the same time, and we're upgrading the dashboards, and so there's still work on it. So I'm going to leave this address URL here, and then when you have a chance, welcome to visit this dashboard. And so with that, I think that's about 10 minutes, and I won't make sure, and I'm not taking up anybody else's time. So, and I don't know, and Carrie, the question should be reserved at the end of all of the presentations,
yes, we're going to do questions at the end, but I was wondering if you wouldn't mind typing that into the chat, your link there, into the chat, so everybody could get access to it.
Absolutely, I'll do that. So,
okay.
Thank you everybody for listening. And if you have any questions, when you get to this dashboard, there is a contact information there. You can always contact us and we go from there. Thank you.
All right, thank you. All right, I think we need to share a screen. So the next up is Dr. Zoltan Nagy, who's also actually in the Department of Civil, Architectural, Environmental Engineering. And he does a lot of work on smart buildings and AI, and he, I think, snagged the best name for a lab, which is Intelligent Environments Lab, which is a description of some of the work that he does. So with that, Zoltan, you can take it away.
Thank you, Carrie, for introducing and setting the bar and the expectations right in the beginning of the talk. So welcome everyone. I'm Zoltan. I'm an assistant professor in the same department as Carrie and John Min. In many ways, John Min gave the perfect talk because I will not talk at all about large scale, but very specifically about one case. It's inverted one. And I will show you a live demo of the website. So it's very, whoever put it up, it's nice. So we'll see the exact the exact opposite. So we'll talk about the data. I don't even want to call it dashboard. It's a website where we show data related to what happened in Austin in terms of the pandemic. Before we get there, let me just show you a little bit what's going on in my group. Like Carrie mentioned, there's a lot of machine learning, AI happening, a lot related to buildings and energy use. But as most of you are in buildings, most of the time, what we're focusing on is also making sure that people are comfortable, people are healthy. We do have an energy transition problem, and so doing that all while making sure that nobody gets left behind is kind of like the essence of our work. Today we'll talk about what's at the bottom right there. The one aspect that is kind of like a group of it all is IoT analytics, systems integration. So where all the things come together, essentially finding ways to generate data, collect data, and return it back to whoever needs to see it to empower them to make decisions based on whatever the goals are. A few examples from the early stages. So this device up here is the first iteration of the device that you saw Carrie showing, one of our first prototypes. Down here, we looked with the UT utilities on where they're leaking not gas, but I'm sorry, steam, sorry, in the building. So when we're losing heating power, basically. So to show them where they should go and check on their valves. We look at how people are using energy and so on. That's what you see here, how these signatures are correlated. So it's a lot of interesting stuff. One first endeavor into GIS-ish environments, if you are on campus, or if you're interested how the air quality is outside of the campus or the air pollution, we did install about 15 purple air monitors on these security poles, together with the ITS, the IT security system folks at UT, who also painted them so they fit right into the environment. And so if you go to purpleair.com right now, you can see for the past year and a half or 2 years, I can't remember, the status of the particulate matter monitors and then temperature and humidity as well, and comparing them, between here Guadalupe or here the I-35 corridor or in the center of the campus, or around the stadium, lets you see whether or not there are spatial differences. I think they're a little smaller than we'd expect them to be, but you have to measure them first to see it. So this is quite exciting. We do a lot of this kind of work where we build the monitors to generate or gather the data and then look at the data afterwards. The sleep quality study that Carrie mentioned in the beginning is done mostly in my group. And so we're trying to understand how, the air quality that you're exposed to in the night impacts the way you're sleeping in terms of, restfulness or REM versus non-REM score. So it's fascinating. So the excursion to the COVID impact dashboard, or the transition to that, very early on, this is like about a year, almost a year ago, maybe a little earlier than more than a year ago, we were sitting around and, all shut down and thinking about, well, everything got shut down. We can't go back to the lab. What's going on? And literally it was this question. So what's going on? How can we find a way to see what's happening in our city or in county or, around in different zip codes without having to pay for data, because nobody wants to do that. There's a lot of data available that you can see. You just have to organize in a smart way. And what we wanted to do is to do the opposite. There was a lot of studies coming out early on that said, oh, look at air quality in 3 different cities, or look at energy use of buildings in 15 different counties. And that's great, but that doesn't tell you anything for the people that live in a particular city. So we wanted to flip that a little bit and say, well, let's find all the data that we can about one particular city. And that's our city. And so that's kind of like trying to, get a hold on documenting what's happened so that we don't lose track of that, seeing if things are changing early on. And so that's what I will show you in a second. So this is just to frame it a little bit, how we came to do what we're doing. A little bit how it's working, very similar to what Jungmin showed. We have data sources on the left-hand side, which are federal, local, state level. Some are one-off data sources, manually updated every now and then. Some are updated daily or every week or things like that. And so each of them require a different aspect of how you pull that data. And then it all goes into our cloud. So we can make a cloud here, right? This is our cloud-ish, where we process the data, prepare the data, generate the figures, and then we push the figures to the website for all to see. And then you can log in and then go to covid19atx.net, and it will show up on your screen. So that's what I'll take you next. But before I do that, whenever you look at data, obviously be careful what you're looking at. Some of the data has different resolutions, so you can't just take one figure and look at the next figure below and try to look at, you know, how things are comparing, because it may not be the same. You may be looking at averages over 2 weeks versus hourly data or versus, you know, spread out over different places and so on. So, or most importantly, because they're different sources, some are already in a certain comparison for a certain time frame, and so changes are reported sometimes with respect to different areas. So that's some big limitations sometimes when you look at these data sets. All right. So without further ado, I'll have to switch my screen virtually, but I'm going to do that right now and move over here. You should be able to see this. This is what you see when you get to the website. So it's a little bit of you know, introduction, which is pretty much what I just mentioned. And then, you know, right on in the beginning, you see sort of like certain policies that have happened over the past year, including, you know, closing down and then reopening, dropping face mask mandate and so on. Some of them here, and then, you know, we're done and back in business in March. And then, you know, you start scrolling, you have the cases for the city, then you start doing it a little bit on zip code. This would look a lot better on the map, but then you would lose the time information. So it's a little bit of a trade-off, because you can see that certain zip codes have had different time evolutions as some others. Some have this clear distinct 2 peaks, others have, you know, one larger later on, whereas others have like virtually no cases. So that can be underreported, but it's quite interesting to look at it. Sorry, this way. And currently we're looking at, you know, analyzing these a little bit more systematically, but this is what you can see for now. And then, you know, there's a lot of data here, so I'm not going to go through it. I'll invite you to look for it for yourself. I'll point to a few things. Here's one that I like in particular because it shows something interesting. This is data. Let me see if I can do. So this is economic data. So it's about where people spend their money, and it's compared to the initial period of, you know, January, February 2020, and then whatever is red you see is increasing in spending, and whatever is blue is decrease in spending. And so you can see grocery and food store, bit of a panic buying here right before mid-March. I mean, right before mid-March, right at mid-March, sorry, when people started to panic and the shutdown was imminent. And then throughout the whole period, you see people have spent a lot more in the grocery store than they have spent on the other area. So you clearly have moved away, or they shifted where money has been spent. And then after that, you see here's the impact of the winter storm here in the February. And then right now, since early March, you see a lot of red, which means, you know, things are getting back to good, as you want to say, right? So I call this the hope part in the data. So the hope's on the horizon, especially down here, food services back to zero-ish, so pre-pandemic levels, which is cool. People are, you know, spending money again more they should. You can also, when you look at this, sometimes there is a second version of the map, so you can click it if you prefer to look at, you know, line plots. It's the same data, except that it has the mean, the average of all these. So you can see the average hovers close to zero, but it just means that people started, like I said before, you know, spending money on groceries and not spending so much on arts and recreation. So the average kind of like hovered where they always been. So the money just shifted. Another interesting thing, okay, this is job postings. The real estate market, you all know, it's crazy town. So this is just the numbers to prove it. Here's one on, you know, inside dining. You know, totally stopped March, April, and then slowly, you know, hovered around 50% less. And then now March, April, we're back to almost normal eating inside. Just kind of neat. And then going down to, and you know, not trying to steal Jianmin's thunder, here's a little bit on transportation. This is Google and Apple's data of where people spend their spots. So that's kind of interesting. What you'd expect, right? Where they are. The one that I like more is about Austin itself. So again, this is data from the city. You know, counters, traffic counters. You can see where the cars are. You can see again a big red line here right before the shutdown, and that was a panic buying mode. After that, it's big shutdown for about a month and then slowly recovering. Some places recovered a lot faster, or you know, went back to normal than others, like down here, Slaughter and Lynch Lane, down south, very much in the light blue. So basically normal conditions throughout, and then already back to higher degrees than before. So that's kind of interesting. Again, here you can click through and look at the average. It's the average traffic across all locations. You see this stop here, mid-March to April, was the one that we put on ourselves. This one down here is about 70% less traffic, which is what the storm put on us. So there was quite a bit of, you know, opportunity to stop a little bit more if you wanted to have to. So this gives us like, okay, what if you really can move, kind of like limit, whereas this was if you really don't want to move, so to speak. But you can see on average, we're down to almost where we have been. And if you're driving outside, you probably noticed that it's almost as if nothing has happened lately. So that's that. And then another interesting thing, traffic, you know, flights, big stop, 90% drop, March, April, and then we're creeping up. We haven't added the most recent data yet, but we're probably back to about 20% less by this time of year. So, and then the last thing I will say before I stop talking, because community is part of whole community's whole health. So one interesting thing also is looking at 211 calls. So this is calls that people make to inquire about certain services that the city has. And this change over time, and it's important to see what's going on, right? So this way you can see what is like important to folks out there. And so you can see here is a shutdown. You can clearly see the line when people start calling about COVID, food stamps applications, food pantry calls right here, payment assistance. And so all of these things that you don't really want to see in the city, but they are happening, mental health increase, calls and so on. These also, we do have these per zip code. We have not been able to completely analyze them. You see a little bit here that just like with the cases, once it loads, I'm sorry, not per zip code, but per individual situations, what are important over time in the city. And we see food pantries, for example, big spike, and then it dropped to regular-ish levels, and then again, a big spike later. So with this, I'll leave you here and invite you to explore, and then I'll take questions later on. Thank you. I think I was in 10 minutes. So good.
All right, you did better than I did. So, but we already knew that was going to happen. All right, great, Zoltan, thanks. All right, our third speaker for today is Dr. Zhongfeng Zhao. He's a chair of actually the other Bridging Barriers program, Good Systems Grand Challenge. He's an associate professor in architecture and also director of the Urban Information Lab. And I think he's up next, so if he can share. There you go, you got it. And perfect.
Karen, thank you so much for the invitation, and thanks for my colleague for two wonderful presentations, Zoltan and Jianmin. So I will pick the last one. So my research focused on urban informatics, trying to understand how people behave in the cities. So in this presentation, we will show you some recent publication, how to use AI, trying to understand how built environments and their other factors affect people's health. This was done before COVID, right before lockdown. So we modeled how the building environment affects obesity, cancer, stroke, mental health, everything else except the COVID. So we probably do a for update. So without further ado, let's get started. So this research trying to understand how the health is related to built environment and other factors. As we all know, trying to estimate the health level is very hard, especially at the neighborhood level. So we're trying to see if machine learning can help us understand this. So the unit of analysis is a census tract. So this is our site, beautiful Austin. I will just skip this. So this is our website. We do also have a website to show you the interactive outcome. I will post the link later. So basically, for this website, for each census tract, you can see the existing health status related to that census tract, obesity, chronic disease, stroke, heart disease, mental health, and so on and so on. You can also change your index at the neighborhood level and see whether obesity will reduce or pollution or health status will improve. So that was, of course, based on predicted results. So this is our framework. So basically, we imagine there's three factors will impact the personal health. One is perceived environment, another is physical environment, the third one is the social environment. And all three contribute to your health behavior, like how many steps you walk, and do you do physical exercise every day, and so on and so on. All these three factors and your health behavior contribute to your health outcome. So basically, where you live, what you do, and who you are will determine your health status. So in order to model out and predict the health status at the neighborhood level, which is census tract level, we have some model structure and workflow. So basically our outcome is different health status at the neighborhood level. The predictor variable include three major baskets. One is socioeconomic status, who you are. The second one is physical health, physical environment, where you live, the neighborhood environment, like the tree density, the sidewalk density, all this beautiful built environment variable. The third one is how you see your environment. Do you like your neighborhood or not? We call perceived environment. All these three contribute to the neighborhood health level. So then we use the machine learning trying to see if we can make any prediction. So this is a breakdown of a different variables. As I said earlier, you have perceived environment, you have a physical environment, and you have a social environment. And we have a different outcome variables. This has two categories. One is direct outcome, like a diabetes, cancer, stroke, heart disease, mental health, physical health. The second is the health behavior, like do you do physical exercise every day? Do you binge drinking every day? Do you sleep well in the night? So this is a detailed workflow of this research. We have a lot of data, and we clean up the data, and we build a model, and we make predictions, and we try different machine learning algorithm, and trying to fit the best that we can. So that's the workflow for this analysis. So, and again, this is our target variable. We have 6 target variables: cancer level, heart disease level, diabetes level, poor mental health level, stroke level at the census tract level, at the census tract, obesity level, and the census tract. So you can think about this as our dependent variable or our target variable. Then we have a bunch of machine learning algorithms from ridge regression, lasso regression, to decision tree, random forest. So we actually have more. We just list a few of them here, because as you can imagine, it's hard to find one machine learning algorithm fit all the predictions. So depend on our targeted variable, we have to test a different machine learning algorithm. So this is how we split the data. We have 80% training data and 20% tested data. So this is basically a model setup. We basically use a root mean squared error trying to measure the performance of different machine learning algorithm. And we of course have other measures, but RMSE is a major one. So this is the way, this is basically the current situation of prevalence of a different disease in city of Austin in at the census tract level. You can see obesity is the most common health problem across Austin. 25% or 24% of residents in any census tract will report will have an obesity problem. Then followed by poor mental health, diabetes, cancer, heart disease, and stroke. This is our current situation. Then we were basically trying to use our models, trying to understand how the different health relate to the three baskets of variables. Okay, this is a prediction result. So you can see basically the model actually performed relative. This is a comparison of different machine learning model algorithm. On the x-axis, you have all these different interesting algorithm from ridge regression to lasso regression and so on and so on. On the y-axis, you have a measure of predict power or errors. You have RMSE, you have R square. So you can see within these 6 different target variables, we are better to predict cancer, heart disease, and stroke. Also, in this figure, you can see lasso regression and elastic net actually perform well in the predictions. So that's a quick overview of a different machine learning model in terms of their prediction power. We will skip this because of time limitation. The prediction power of different feature of a different disease. This is basically show you in terms of the combination of a different data set, how well we predict the different disease. So basically you can see again, we predict pretty well for stroke. There also we predict pretty well for cancer and chronic disease, heart disease. We don't predict so well for other 3 health outcome. In terms of variables, this is very interesting. I want to mention that it's not the more data you put in a model, the better. Actually, sometimes the more data you put in a machine learning a model, it have a negative impact. For example, basically, you can see we have a 311 call data set. We have a socioeconomic status, and we have a built environment variable. So basically, we tested them individually, then we tested different combinations. So basically, you can see not for a specific health outcome, you don't need to put all 3 variables. So you have to determine which data set to put in. So this is a summary of a different prediction models. Trying to give you a quick explanation. For cancer, the best machine learning model is random forest. And the data set is socioeconomic variable plus built environment variable. For chronic heart disease, the lasso regression is better. The best data set combination is socioeconomic variable plus 311 calls. So I will basically skip this. Basically, this trying to show you for different health outcome, you have to use different machine learning models, and you have to use a different data set. It's not like kitchen sink. You can put all the data in one model, and you can apply it universally to other all variables, all health outcomes. So that's the finding from this slide. So this is our prediction result. So again, you can see cancer, heart disease, diabetes are relatively well performed in our prediction model. So let's see the actual result versus the predicted results. This is on your left, it's actual result for cancer. On your right, it's a predicted value at the neighborhood level for cancer percentage. So you can see they're pretty similar. Of course, it's because we use a one city data set. We have not tested the model in other cities in Chicago or New York or other cities, but this is for Austin. This is a comparison between diabetes. You can see they're also very similar. You can find some minor difference in terms of color, like this part, there's little different. The predicted result is a little different with actual result. This is poor mental health. And this is a heart disease level. Again, you have a minor difference, like this part of cities is a little different. Also, this part of city is also a little different. So what we found from this different model, we found the built environment variable actually has only marginal impact on personal health level, or even at a neighborhood level. So it's not that we thought like where you live will directly affect your health level. At least according to this model, built environment or neighborhood environment had a minor impact on your health status. So the most common or most powerful predictor variable is, of course, socioeconomic status that had a directly and a very strong prediction power at the individual level, also at the neighborhood level in terms of health status. Also, the perceived environment measured by density of 311 calls has a relatively good prediction power in terms of health outcome. So the ranking of the three basket of variables, socio-economic status, then perceived environment, then built environment. Okay, so basically we found different models had a different application in terms of health outcome. Lasso regression actually pretty good. And it's not always use a complicated machine learning model. Sometimes you can just use simple regression-based machine learning models to get good results. Also, we expanded this analysis to 10 US cities. This is a team, so there's a collaboration project between different part of the university. It was supported, as Karen mentioned, a broader grant challenge called Go System. So it's good to see we have a cross neighborhood level research. So, okay, this is a website, basically site.utexas.edu, the URL. And this has been published. So if you're interested, you can download from Computer Environment and Urban System. So that's all. Thank you very much.
All right, thank you. All right, so we have some time for some questions now. So I think maybe let's go back to just where we're full screen here with everybody. If anybody wants to join via video, well, now we got a good screen to use, Alton. Great. Actually, those were amazingly complimentary. I enjoyed every single one of those talks. So does some folks have some questions in the audience here? You can put it in the chat or just pipe up.
Carrie, can I ask a question? This is Vince.
Go ahead, Vince. It's all yours.
I was particularly interested in the last speaker, not so much from the predictive capability, but it's interesting to see how I can predict. One of the areas that you didn't use data from had to do with schools and how school data, I know everything that you're working with was census tract data. Have you done any work with school data, geocoding of where students of different age groups live, and how your predictive capability might be useful for predicting those same parameters in school-age children of different ages?
Yeah, thank you for the question, Vincent. In Austin, we have not, my lab have not done school level research, but previously I've done like geocode all the schools in Seattle and try to understand whether students walk to school or driving to school, depend on their built environment of where they live, and also depend on the built environment of around the schools. To answer your question, that's be a very good research topic, trying to predict the health outcome of a different age group based on the school location. Thank you.
We have some other questions?
We have a question in the chat. What is the time resolution that you recommend these dashboard products be used? And what is the best optimal application that is still unexplored and you would like to do next?
So we'll open that up to all the speakers there.
Yeah.
I'll answer with a question in the Holcomb spirit. I think the best dashboard product is the one that allows you to visualize something that you're interested in, and then none of these are necessarily working for everything you're interested in. So I think we're looking at, and this is specifically part of, I think, whole communities, whole health, is how do you actually visualize these dashboards in a way that is useful, not for researchers, but somebody who does not want to spend a day understanding how the interface works, but is interested in the data that's related to them specifically. So, we see a lot of these products right now because you can do them and it's awesome. But I think that there is a step missing, which is how do you make them useful for everyone in a simple way.
And we've come to the end of our time, but I was wondering, Dr. Kinney, if you could share, if people are interested in learning more about whole communities, whole health, or joining us as a faculty member or graduate student, if you could give a little bit more information about that and who they should get in contact with.
Yeah, I think that they can just either contact myself or Darla Castelli, who I see is on here. We're both co-chairs for that, for the Holcom this year, Whole Communities, Whole Health, sorry. We always shorten it. And I'm sure with good systems, the same could be true for the chair that's well represented here as well. So I think this really is a great opportunity. We, for instance, in our UT, we call it 1,000, 2,000, X thousand data sets. We have so many data sets actually that we've generated that we've actually having trouble making it through all of those data sets. And there's a huge opportunity to get involved if this or the other bridging barrier research themes, fit within your interests. But certainly with whole communities, we are working very hard to work with the community members to help them, have them help guide our questions. But I can tell there's already overlaps in the presentations today. So for instance, I've already jotted down a few of the data sources that each of you have mentioned. So I think that, one of the, maybe we'll call it the grandest of all challenges, is to bridge across the bridging barriers here. Good systems has many things that the whole community's whole health can benefit from, and vice versa. And the same, it could be true for PT 2050 effort, which I know that several folks are involved in multiple ones of these grand challenges or these bridging barrier programs. So just reach out to Darla or myself, and we will certainly get back in touch. And you have the contact information, of course, for each of our speakers today, so you can reach out directly to them as well.
Thank you. Thank you all for attending and for the interesting presentations.
All right, great job.
Take care.
Thanks, Carrie. Thank you to all the speakers.
Thanks to the speakers.
Thanks, everyone.
Bye.